you've chosen to watch Sacroiliac Joint Syndrome, a common diagnosis after major pelvic trauma, an uncommon diagnosis for patients who complain of, oh, my back hurts, after not major trauma, possibly at work. So let's take a look at how you examine someone with, in this case, left symptomatic SI joint syndrome, or at least that's what you suspect. So you have to visualize the back, usually from the TL junction down to the gluteal cleft. One has to find and localize the posterior superior iliac spine on the right versus the PSIS on the left. Mark it if you're not sure. A black X will do. Directly medial to that PSIS is your SI joint, about a finger breadth below the PSIS. That's the entire SI joint excursion. Palpating the asymptomatic right side should give no localized tenderness. Palpating the PSIS, or just medial to that, on the left side, the symptomatic side, should give local tenderness and discomfort, even to thumb tip palpation. So now let's put the patient at the supine position and be much more provocative in our examination. There are 3 classic maneuvers that should be done not one time, but every visit over several serial visits to diagnose SI joint syndrome. Let's take a look at the first, known as the Faber maneuver. Flexion, abduction, external rotation, F-A-B-E-R. Let's take a look at the asymptomatic right side in this case. Flex the hip up, allow it to abduct and externally rotate, and manual pressure at about the level of the knee in an abducted manner should not produce pain on the asymptomatic side. Do that similar maneuver, a Faber maneuver on the symptomatic side. Now pushing that knee down will give localized pain and discomfort, almost to the point of 1 or 2 finger breaths to the SI joint on the symptomatic side. Let's go to the second provocative maneuver known as a Gainsland's test, popularized by Dr. Gainsland from the 1920s. Here you have to put the asymptomatic side off the edge of the table. See where we place the patient's right leg in a fully extended manner at the hip? Now let's go to the symptomatic side, allowing that hip flexion up, externally rotating and putting manual pressure down. You put all the pain and discomfort on the SI joint on the symptomatic side. That again should produce focal pain and tenderness at the SI joint. Let's go to the third provocative maneuver known as a thigh thrust. Again, train the patient on the asymptomatic side, the right side in this patient. Flex the hip up, manually control the condyles of the femur, and by putting direct posterior pressure on these condyles, you can have the femoral head push on the acetabulum and put pressure on the right SI joint. Should not produce pain or discomfort. Now let's do the symptomatic left side. Put the position of the femur in the same manner, and with a good amount of weight over the condyles of the femur, posteriorly thrust up and down that femur against the acetabulum and try and disrupt the SI joint. Ask the patient, does that hurt? He should point locally and focally to the left SI joint on the symptomatic side. Your documentation and your clinical notes is how you and Texas Mutual will arrive at the correct diagnosis. Only by documentation of pertinent positives and negatives can we define the workplace injury. Thank you for watching Workplace Diagnosis.